After all these dynamic talks from the perspective of the industry, of the governments, of the taxpayers, of all those stakeholders, let me add some skepticism from the point of view of the patient. And the skepticism comes from several points. One is, for example, it was now exactly 30 years ago that we obtained a patent for computer-assisted surgery, a navigation system for surgeons, and it took 20 years until it came into practice and it was generally used. And 25 years ago, we designed knowledge-based system for optimal therapy in ENT surgery, and they've disappeared, they vanished. So what I have learned from that, my lessons from that is that progress in medicine can be very slow, it moves like a worm, and it may take rather decades than years until it comes to the benefit of our patients. And that is why maybe we should focus more on the needs of the patients and look at progress from a patient point of view, and then I think progress will come much faster. So these are the companies I've worked for. These are my disclosures, my recent disclosures, so you see I'm absolutely unbiased. What I want to point out is the dynamics of this disease that we see. Diabetes has been there for a long time. All these diseases have been there for a long time. Allergy is a German invention. 110 years ago, it was Clemens von Pirket who published the concept of allergy, just 110 years ago. And at that time, he was a pediatrician. When a patient came to his ward, all the doctors would gather around this rare patient, this rare disease. It was an absolute orphan disease, we would say today, just 110 years ago. Imagine that. And ever since, we have seen this dynamic growth of the prevalence, exponential growth, and we are at a certain point. It was 10 years ago that 1 out of 4 children in Europe had an ongoing allergic disease, and we thought, okay, when a child has this disease, this may go away when the child grows older. This is, in fact, the case in eczema, as you see from these curves here, 100% having it at the age of 3, and 90% of them lose their atopic dermatitis or atopic eczema. But for rhinitis, this is not the case. Once you have it, you will keep it for the rest of your life. And it's not a disease of the young only, but also of elderly. My father had his allergic rhinitis, or started his rhinitis career after me at the age of 48, and he still is suffering from allergic rhinitis now at the age of 89. So this disease does not go away, and I think this is a concept that we have to keep in our minds. Don't wait for tomorrow, it will be better tomorrow. This, for most of our patients, this is not the case. We have to do something about it. And here we were talking about the disease, but let's look at sensitization. Disease is only the tip of the iceberg. We have much more sensitization in our community. In Austria, 50.8% of the general population has a sensitization. In the German KICS survey, children and adolescents, 51% of our adolescents now have an allergic sensitization. In the US, it was 54%. And so these data are very similar, so that we had the concept, yes, it's the genes, and only 1 out of 2 has the genes. You have it, you don't have it, your neighbor doesn't have it. But when you look at the most recent data that come from Singapore, our friend and colleague De-Jung Wang set up this epidemiologic trial within the community of Singapore. He found that in Singapore, with a high exposure to house dust mite and a very clean environment, nobody is allowed to spit on the ground there. In this environment, about 80% of the population are now house dust mite sensitive. And in parallel with this, we have the growth of allergic rhinitis up to 40% now, and also asthma is growing. So I think this is something we have to keep in mind from the patient's perspective. Soon everybody will be allergic or have an allergic sensitization. This is not genetically determined that you can be sure you will not get it. Depending on the environment, everybody will have it. But then, as we heard before, it's a banal disease. Nobody's dying of allergic rhinitis. I will show you other figures in a minute. But yes, there is this sneezing, this little drop at the nose, the blocked nose, but from a patient's perspective, a patient may feel, as this patient said here, I feel like a zombie when I have this disease. It's just sneezing, itching, watery rhinorrhea, but for a patient, he or she feels like a zombie. And many have sinus disease, recurrent sinus disease, are treated with antibiotics, but nobody looks at the underlying disease, which is allergic rhinitis. These are complaints of patients or their spouses not being able to sleep, snoring, and so on, being embarrassed. This has a meaning for the patient more than you would guess when you look at the little drop at the nose. And it has consequences in your professional life. We had Julia Görges last year. She played at Roland Garros. She beat the world's #1 on a rainy day, and the next day it was sunny. There are trees around the courts in Roland Garros, and she needed 120 tissues and lost to somebody she would normally beat. These are the consequences. And this is just one case study, but here you can see 1 out of 3 children suffering from allergic rhinitis complains about not being able to have organized sports, to enjoy outdoor activities. This is what we have to keep in mind. And when these children then grow older, they have other problems. And there's not much studies about this problem, but it exists, it is there, and it has a major impact on people's life. 50% are now suffering from this disease. So allergic rhinitis is not a trivial disease. Quality of life is reduced, and we have learned about school and work performance before in in the talks before. Patients must be treated. And why? We often say, yes, sedation comes from the drugs that we prescribe, but the disease itself causes sedation. It makes our patients sleepy. This has consequences for work and school. We have heard about the presentism. We have heard about students not being able to perform as they could be. And this is again a case study that I took from a newspaper. A boy with hay fever who remembers doing his GCSE, was sitting there with a box of tissues. Everybody was getting on with the exams, and he was blowing his nose all the way through and did not manage to pass his GCSE. It did not prevent him from making millions of dollars every year. You all know him. But yes, it is a game changer it can be a game changer for your career if you don't pass your exams, if you don't manage to get the A's all over to go to medical school. This is what we have to keep in mind. And yes, Samantha Walker has studied exactly this case with the GCSE in England being performed in 2 steps, one in winter, and then she looked at those who deteriorated in their performance at least one step during summertime, and she found there was a 40% higher risk of deterioration in your performance when you were an allergic patient. And then, as I often say, the United Kingdom is a developing country as far as medication is concerned. You are urged as a GP to prescribe first-generation antihistamines, and if you do that, the chances of these children were even higher to deteriorate. I think this is one point. We have to look at this, at all these facts, prescription, habits, and so on, from a national and sometimes from a regional perspective. There are differences between the UK, where everybody has to go first to the GP, or in the Netherlands, where everybody has his huisarts and he does not have a chance to go somewhere else. In my country, in Germany, everybody has a kind of credit card and can go to every specialist wherever he wants. We have different pathways, and we have to keep that in mind, and this has consequences on prescription habits. We can prescribe immunotherapy to every patient that comes, but we cannot prescribe an antihistamine. You know, these are different ways of different pathways that we have. Yes, and now I can tell you, I put a bet on this gentleman here, saying he will be the next Formula One world champion. And why am I so sure? Because the kid that did not pass his GCSE was this gentleman here, Lewis Hamilton. He's suffering from allergic rhinitis. He needs sometimes during a race 110 tissues while he's driving. Can you imagine that? And the rest of the article was, as you can see here, he hadn't driven with hay fever for a while, but in England, at the English GP, he had to drive, and he was sure he will be fine, but he wasn't. And you can exactly see it was this stretch where we have this period of time where we have high pollen concentration, where he lost the world championship. These can be examples from sport where you can measure performance very exactly, but this applies to practically everybody of us if you are suffering from allergic rhinitis and not treated well enough. Imagine having a sneezing attack when you're driving at 300 kilometers per hour, you know. These are the consequences for your patients that you may never think about. Well, not everybody's driving like this, but also statistics show that 80% of major aircraft accidents involve human factors, and the most frequently found drug in the blood of crashed pilots were antihistamines, first-generation antihistamines, because in the US you can just get them over the counter. And yes, in Germany we have one example that happened in France a little more than a year ago with a patient who was suicidal. And allergy is also a risk factor for suicide. Why do I speak about that? I speak about that because we have epidemiologic data from Taipei, from Taiwan. They looked at 1 million of Taiwanese. It was a study also aiming at sexual dysfunction, and they found, yes, this exists also in a large sample, but they looked at this, this cohort, one being allergic and the other not being allergic, and during a time span, the mean age was 34 years of these males. During a time span of 6 years, 500 of those not suffering from allergic rhinitis died. If you have ever been in the traffic of Taipei, you know how that can happen. But in the group of allergic rhinitis males of the age of 34, 3 times as many died. The relative risk for death, if you are an allergic rhinitis patient, was 3 times higher. And nobody knows why. It could be suicide, there could be other factors. We don't know about that. Nobody has ever studied that. So let's look at it from a patient perspective. There is clearly undertreatment in Europe. In Germany, it's the antihistamines that are missing. In the UK, it's mostly immunotherapy that is missing. We all have these deficits, and we see that 1 out of 2 allergic patients does not consult his doctor anymore. Why can that be? Is it better in the United States? No, it isn't. There is this nationwide survey by Jennifer Darabif and initiated by Eli Meltzer, and they found that control of nasal symptom was only there in 40% of allergic rhinitis, whereas 60% were uncontrolled. So a very similar situation in the US as it is in Europe. And this brings us, of course, to the concept of control. It was brought up to the public in this review paper in Allergy 2 years ago. And it was the idea, it was the invention. I said allergy is a German invention. Control of allergy is a French invention by Jean Bousquet, who brought this concept up. A very simple concept if you handle it with the VAS scheme. I have it here for China. You see, these are the Chinese equivalents to that. In China, it makes sense. And I think we also, from a patient perspective, we have to look at the individual situation in the country. I attended the Chinese allergy meeting recently. There were 480 allergists sitting in front of me for a country of 1,400 million inhabitants. In Germany, it's the other way around. We have 10,059 for a country of 80. So in a country like that, of course, it makes sense to have more patient-driven therapy. And yes, you know how this functions. We have heard about this wonderful application that may help Chinese population to get better access to therapy and better treatment following this algorithm that our organizer here, Professor Hellings and Jean Bousquet, have set up, from first-line treatment going with this algorithm to second-line treatment. However, what are the treatments, the first line, second line, and other treatments that we have? We have immunotherapy, of course. We can interact with the interleukins. Nowadays, we have those monoclonal antibodies. We have anti-IgE on the level of the antibodies. We have mast cell stabilizers. We have the antihistaminics. We have PAF antagonists now. And of course, we have very strong glucocorticosteroids. There is everything available to optimize our therapy. Again, my skepticism, this slide is from 1988. So there hasn't been any major breakthrough since 1988 in our field in terms of pharmacology. This is something we also have to keep in mind. So there is need for improvement and more research. So we are stuck with this. We know that SCIT and SLIT, the immunotherapy, are the most powerful tools in our armamentarium that we have. But still, 60% of our population could be candidates for immunotherapy. How many do get that in the end? In Germany, it's about 7%, and we are the paradise of immunotherapy. The patient, why does the patient not have access to a therapy that promises cure? This is the only treatment that we have that promises cure. And we did a survey in a large population of patients before immunotherapy and on immunotherapy. Before immunotherapy, 99.5% hoped to get cure from immunotherapy. And when they were on, 100% said, yes, I'm determined to have my allergy cured. Is this a promise that we can keep? There are data now on the long-lasting effects. Yes, in the beginning, allergy disappears, but it may come back in many cases. And this is what we see, patients coming back after 5 to 10 years after successful immunotherapy. And the options are, what are our options to treat them? How can we convince them to have a second course of immunotherapy when we have the problem with compliance? I think this is essential from a patient point of view. Why should I undergo a cycle of 3 years of treatment when I don't receive cure from that? And that is why, if you look at adherence, in this case of sublingual immunotherapy, the full course of 3 years was only in 15%, 15%. 85% stopped their immunotherapy before that. Are these patients, well, not well educated? It's the number that we have heard before. You know, the guidelines say do this or that, and in the end it's 1 out of 6, 1 out of 7 who follows this. But yes, maybe we looked at, the other figure was from Italy. These are the German figures, similar. We have 50, 1 out of 2 to 1 out of 3 who is following the guidelines all through the 3 years course of immunotherapy. But small wonder if you hear about SCID fatalities, if you hear about the risk of anaphylaxis. This is something we have to communicate to our patients, that there are new therapies coming up, like the peptide immunotherapy, for example, with practically no side effects that we have seen in our clinical trials. And then you may say, well, you can switch to SLID. Why is the compliance and the adherence with SLID so bad? Yes, many patients have this feeling when they use the current SLID that we have. In one study published, we had 73% of patients suffering from major local side effects. So small wonder also that patients turn to other medications like homeopathy. It was interesting, the number 1 diagnosis in males in Germany for homeopathy was allergic rhinitis. This is what our patients, where our patients hope to get relief from. And also from acupuncture, which is very popular in our country. 2 out of 3 allergic rhinitis patients in our country do not want pharmacotherapy, do not want immunotherapy. They want this kind of treatment. And we have to keep that in mind and improve the therapies that we have and show them that, for example, immunotherapy is the most natural treatment of the disease that there is. Acupuncture is, by the way, effective. We have published this study in the British Medical Journal. So, to summarize, the allergic patient is the normal person within our population now. It's the majority, more than Trump ever got from his votes. We would, somebody who could attract all allergic patients for his party would be the strongest person in Europe now. Allergic diseases have a major impact on school and work performance, but we should not only think of fit at work. You know, there's more to life than only work, and we should also think about leisure, well-being, and all the other factors that are impacted by the disease. There should be access to optimum treatment in all parts of Europe, and not this heterogeneity that we see over all our countries. Disease is, this is another point, is insufficiently controlled in the majority of our patients, and they suffer in one way or another for that. And this, in spite of the fact that we know the strategies for better care, we only have to implement them. Thank you very much for your attention.